Thanks, Cliburn. Before we turn this over to John, just wanted to say, you may be wondering, where's the SBS Corps? And actually, the Corps leadership is in South Africa and on the road. And so SBS actually has an extraordinarily broad repertoire of services that they offer, all available on the Duke CFAR website. So we haven't forgotten about SBS, obviously. And so with that, let's have John finish up this session.
So thank you, Kent. On behalf of the Clinical Core Co-Director, Colleen Cunningham, I'm pleased to make this presentation today. So I have 4 objectives for this short talk. The first is to share the Clinical Core survey results. Secondly, to present the resources of the Clinical Core. Thirdly, to describe Clinical Core activities. And then I hope to encourage Clinical Core utilization, because we want to be busy. So as Kent mentioned, earlier this year we had a survey of all of the different CFAR cores, and amongst them we surveyed potential Clinical Core users. And we only received 5 responses, which was a bit disappointing. And as you can see from the results with regard to overall satisfaction and how connected people felt within the Clinical Core, we felt the message was a bit disappointing. So we've tried to take this quite seriously. And as we go through Clinical Core activities and I think expectations for the future, I hope you'll see that we're trying to respond to this less than enthusiastic response. So with regard to specific suggestions from the Clinical Core survey, there were suggestions to replace the coordinator position, to have an improved link to international samples at KCMC, to offer more pre-submission peer review, to have more opportunities for discussion within the Clinical Core, to have an improved and expanded clinic database, and to have more community activities. Well, with regard to Clinical Core resources, probably the most important resource we have is access to patient samples. And we can do that through a number of different clinical settings. First of all, there's the Duke Pediatric Infectious Diseases Clinic. They continue to follow about 100 HIV-infected or exposed children and adolescents. Within the Duke Adult Infectious Diseases Clinic, and I'll give you substantially more information shortly, we follow almost 2,000 HIV-infected persons. The KCMC Adult Infectious Diseases Clinic follows about 2,000 HIV-infected persons in an environment where subtypes C and A predominate. The KCMC Child-Centered Family Care Center follows about another 2,000 HIV-infected persons. The Mwenzi Care and Treatment Center, which is located in downtown Moshi, Tanzania, follows about 6,000 HIV-infected persons. The TPC Care and Treatment Center, which is just outside of Moshi, follows about 10,000 HIV-infected persons. So within Tanzania, we have access to about 20,000 people living with HIV infection. Now, apropos to the comments of Marcella earlier, we have quite good laboratory infrastructure in Moshi. We use good clinical practice when recruiting subjects. We use good clinical laboratory practice when handling patient specimens. The laboratory participates in the immunology quality assurance proficiency testing for archiving of peripheral blood mononuclear cells. So there's quite a robust platform that you can access there in order to recruit subjects. And then finally, I wanted to mention 3 repositories. There is a repository of plasma samples at Duke that Chuck Hicks oversees. Currently, that repository has about 55,000 plasma samples in it, so it's quite substantial. through Colleen Cunningham and through myself, you should have access to repositories both for IMPACT as well as the ACTG. The ACTG repository now has multiple millions of samples that could be accessed potentially. Well, a few comments about the Adult Infectious Diseases Clinic. 1,960 active patients, 28% are women, 57% African American, 4% Latino. As Mary McKellar mentioned earlier, 42% are over the age of 50. And Ken, we have 2% between 70 and 79. Thank you. 53% of our patients have current CD4 counts above 500, and 86% have CD4 counts above 200. We are able to provide care to all patients who come to our clinic thanks to the leadership of the Duke Health System. Now, we have a diversity of clinical core services that we can offer to you. We can assist with study design. We can help with linkage to patients and repositories. With the able leadership of Kathy Link and Stuart Carr, we can provide regulatory assistance. We can help with subject recruitment, obtaining specimens. We, once again, are going to start to reorganize Chalk Talks. As Ken mentioned, the first Chalk Talk will be next week. And we can also assist with coordination of training opportunities. So Chuck Hicks is the principal investigator for the T32 AIDS training grant. If you have international trainees who are in need of support, I'm the program director for 2 HIV-related T43 training grants. So I thought I'd share a little bit of data with you from the Year 8 Clinical Core Progress Report. And that is to say that we assisted 32 users with 113 projects last year. That included 80 NIH-sponsored projects and 5 CFAR small grants. In addition to the example that Tamika mentioned earlier about recruiting long-term non-progressors, I thought I would highlight 2 examples, one being the Pratt pouch. This is a pouch that was developed for dispensing a single dose of nevirapine to neonates. This was developed by Bob Malkin in the School of Engineering and has been highly heralded. Former Secretary of State Hillary Clinton declared it one of the best inventions of the year, and the WHO listed it in its top 10 inventions. The second example that I wanted to highlight is a prevention of mother-to-child project conducted by Annie Buchanan in Tanzania. They have about 5,000 dried blood samples, and it's a fantastic example of an implementation science project that's currently in press at PLOS One. What they've been able to demonstrate is through the implementation of PMTCT guidelines, perinatal transmission of HIV infection in these regions of Tanzania has now declined to less than 2%. Well, what about clinical core developments and how have we responded to the feedback? Well, first of all, we have interviewed candidates for the clinical coordinator, and we hope to be making a job offer soon. Secondly, the database and repository is nearing completion under the leadership of Chuck Hicks. Beta testing has been completed. They found some minor programming revisions to be made, and there are 3 studies currently in progress that are accessing samples. Kent asked me to address how MaestroCare may be able to impact on clinical core activities. And ideally, MaestroCare may offer some advantages in that it should collect medication start and stop dates. It should collect information on substance abuse and other behavioral variables. We will still need deduce to access research questions within MaestroCare. MaestroCare can be used to deliver interventions, but please remember that regulatory approvals will still be required for individual studies. Then finally, I'd like to highlight some enhanced CAB activities. Recognize David Palm, who's here from the community. Royce Harden, another community member, has been quite active within the new CFAR CAB structure. We sponsored him to go to Philadelphia early this year and participate in community CFAR activities. So with that, Kent, I'll close.
Okay, thank you, John.